the basic plan of this paper is just to make sure you are into that habit of solving the MCQs, just reading the MCQ statement without going into the options, because at times what happens when you go into the options, you are confused so as to which one is the answer, right? So I'm just trying to give you a trick, or you can say the technique how to derive the answer from the question statement. Okay, so I'm very sure it will help you. So starting with the very first question, a male presented with merciful anosmia, and there is wide roomy nasal cavity, and there is formation of crust and nasal obstruction. Now, I think the moment you have these keywords with you, most of you will be in a position to answer this question absolutely right. So, the moment you have this word, merciful anosmia, and wide roomy nasal cavity with crust leading to nasal obstruction, the answer is pretty clear. This condition is atrophic rhinitis. Clear? This is atrophic rhinitis. Now, whenever there is itis word, Muhammad Anash, hello. So, whenever there is word itis, yes, this is inflammation. But if you look properly, there is one more word, atrophic. And I think most of you must have read, Chaitanya, hello. Most of you must have read in pathology what actually atrophic is. Atrophic means there is reduction in the size. Now here, what are the structures which are reduced or which are atrophied? So one structure is the turbinates, right? So one structure which gets atrophied is turbinate, and the other structure which gets atrophied here are the nerves. Clear? So there is atrophy of turbinates and there is atrophy of nerves. Now, you all must be knowing what is the function of nerve. If the nerves are atrophied, there will be no sensation. And in case of the olfactory nerves, the sensation is of smell. So it means the patient will develop anosmia. That is, there is no sensation of smell. So this is why there is anosmia. Now, the other thing is there is atrophy of turbinates. Again, because of this, there are two things. One thing, there is emanation of bad smell. Clear? So one thing is there is emanation of bad smell from the nostrils. And secondly, what will happen? Now, if you look in the image on the left side, this is the middle turbinate. Clear? So you see, this is such a big structure here. So this is the middle turbinate over here. And it is filling so much part of the nasal cavity. Now if I show you the middle turbinate, in a case of atrophic rhinitis, it is atrophied. It has reduced so much in size. So this is the atrophied middle turbinate. Similarly, if I draw the inferior turbinate, see the inferior turbinate over here. It is such a big structure. Clear? So this is all inferior turbinate. Now look at the inferior turbinate on the affected side. It is such a small structure. Now what is happening because of this atrophy of turbinates? The nasal cavity which was occupied by these turbinates is now empty. So you can see this is known as roomy nasal cavity. Clear? Why roomy nasal cavity? Because of atrophy of turbinates. So atrophy of turbinates is leading to two things. Number one, emanation of bad smell, and secondly, roomy nasal cavity. Now what happens? There is bad smell coming from the nose. So if anyone comes in close contact of the patient, he or she will run away because of that bad smell. But the problem is that patient does not sense this bad smell because he is having anosmia. So the patient does not understand why my relatives or my friends are avoiding me, why they are running away from me. Because the reality is there is so much of bad smell, no one can stand in front of the patient. But the patient himself or herself is anosmic, so he cannot appreciate what degree of bad smell is coming from his nose. So this is known as merciful anosmia. Clear? And then the concept of wide roomy nasal cavity, that is also clear because it is because of atrophy of turbinates, right? So this is a beautiful explanation, and the moment you have these keywords, merciful anosmia, wide roomy nasal cavity, crust and nasal obstruction, of course because of those crust, the answer is atrophic rhinitis. Now here, how the examiner will trouble you. See the word roomy nasal cavity. Sometimes there is one condition in which we use the word woody nose. Clear? So if you find the word woody nose, do not mix up. Woody nose is rhinoscleroma. Clear? So roomy nose, atrophic rhinitis, and woody nose, rhinoscleroma. I'm very sure you won't mix up in this particular facts. Moving forward, an elderly patient with bilateral neck swelling, temporoparietal neuralgia, and unilateral conductive deafness. Now I think most of you, yes Anas, you are absolutely right. Now most of you, the moment you get these words, temporoparietal neuralgia, you can think of the trotter stride. Then the moment you have this word, I think this single keyword is enough for you to get to the answer, and the answer here is nasopharyngeal carcinoma. Very good, Mohammad Anas. So this is nasopharyngeal carcinoma. So this is a classic keyword here for NPC, temporoparietal neuralgia. Now, of course, this is a component of Trotter's triad of NPC, in which there is, of course, one is temporoparietal neuralgia. Now, neuralgia is nerve pain. Clear? Second is palatal palsy. And the third one is the conductive deafness. Clear? Now, the question is why there is conductive deafness and not sensorineural deafness. The reason is that there is blockage of the eustachian tube, which lies in the in the nasopharynx. So there is blockage of eustachian tube, and this can lead to serous otitis media, or what you call glue ear, or otitis media with effusion. So it has different names. Now, so this is the cause of conductive deafness here, right? And one more thing, that this may be associated with Epstein-Barr virus. Okay, so this is a classical description of nasopharyngeal carcinoma. Now there is one point which I want to describe here, bilateral neck swellings. Now these are actually enlarged lymph nodes. Okay, so these are actually enlarged lymph nodes. So the word swelling is actually enlargement of the lymph nodes, which is a feature of nasopharyngeal carcinoma. So the moment you have this, again, elderly here, because if we talk about the age incidence of nasopharyngeal carcinoma, this is bimodal. There are two peaks, one in younger patients, and this another peak can be seen in elderly patients. So most of the time the question might start with elderly patient. Otherwise, at times it can start with young patient also because it is bimodal, right? So this is a classical description. The moment you have even a single keyword, I think you should jump to the answer as nasopharyngeal carcinoma. So these are very basic questions, and I expect student not to make any suicidal errors here. They should mark the answers at the earliest, save your time, secure your marks, and go ahead. Okay? So if you look in the image here, you can see this is nasopharyngeal carcinoma, and this is the eustachian tube opening. So this tumor mass actually blocks the eustachian tube opening. Okay, moving forward. Now, which is not seen in Meniere's disease. So not a feature of Meniere's disease, and the clinical features of Meniere disease can be remembered by the mnemonic DVT. If you know the deep venous thrombosis of surgery, so D is for deafness, clear? V is for vertigo, and T is of course for tinnitus, that is ringing of ears. So please don't do any sort of mistake in such easy questions. DVT, and yes, the answer is loss of consciousness. That is not a feature of Meniere's disease. Chaitanya Anash, absolutely right. Now, the deafness here is sensory neural hearing loss. Why? Because it is affecting the inner ear. Clear? So it is affecting the inner ear. So this is a sensory neural hearing loss. Now, what happens actually? What is the pathology in Meniere's disease? This is somewhat like glaucoma of the eye. Now here there is excess production of or poor reabsorption of endolymph, which is present in scala media, right? So there is excess of endolymph, and this is present in scala media in membranous labyrinth or the cochlear area. Now just note down that in scala vestibuli and scala tympani there is perilymph. I think most of you must be knowing that. So this is in short about Meniere's disease. Now the next question is a very easy question. A patient hears better in noise. What clinical condition we are discussing about? Now the patient here is actually having conductive deafness. Okay, so he is having conductive deafness. Very good, Mohammad Anas. This is paracusis willisii. Great. So this is paracusis willisii, and what happens? The patient is actually a case of otosclerosis here. Right? So the condition which is being discussed here is otosclerosis. Now what happens? The patient is having conductive deafness. But what happens in noise? People talk louder, isn't it? If there is so much of noise, the people surrounding the patient will talk louder, and the patient takes advantage of this high volume, and therefore he listens or he hears better. So that is known as better hearing in noisy surroundings. It can be a party or a marriage procession. So anywhere when the people are forced to speak louder, patient hears better. So this is known as paracusis willisii, and the moment you have any sort of hint regarding this, straight away go to otosclerosis. Do not do unnecessary post-mortem of the question. The moment you have keywords, mark the answer, move ahead. Now moving forward, a known case of diabetes is not properly maintaining the sugar levels, and now he is having facial nerve palsy. And there is severe pain in ear also, and there is discharge from the ear. And then on examination there was granulation tissue which was found at the external auditory canal or external auditory meatus. Now what is this? A diabetic with poor sugar control. This is one thing. then earache, right? Then there is granulation tissue, and moreover, the condition is leading to paralysis of facial nerve. So this is causing seventh nerve palsy. Now what is this? Very good, Chaitanya. This is malignant otitis externa. Clear? Because we are discussing something related to the external ear, right? And especially in a diabetic person, the condition is more severe. So it is known as malignant otitis externa. Please note that here this is a wrong word actually, because this is not a tumorous condition. It is just the infection is so severe that it can involve a cranial nerve as well. So the malignant word is actually just for comparison with the severity of the condition. Otherwise, it has nothing to do with a tumor. So this is malignant otitis externa, right? So especially in persons who have poor sugar control or immunocompromised state, we can have this kind of picture, right? So please remember malignant otitis externa. And yes, just to add, this condition is caused by Pseudomonas aeruginosa. Clear? So this is caused by Pseudomonas aeruginosa. And please remember, if the term is simple otitis externa, that is caused by Staphylococcus aureus. So if it's simple otitis externa, this is caused by Staph aureus. Right? So please remember the difference. Here you can see there is involvement of the external auditory canal. Clear? So this is malignant otitis externa. Now moving forward, a diabetic male with uncontrolled sugar presents with dyspnea, fever and generalized malaise. There is tachypnea, and then RT-PCR was positive for COVID virus. And then he developed swelling in the periorbital area, and there is proptosis of the right eye, which, yes, Mohammed Anas, absolutely right, especially in a diabetic person with poor sugar control, then difficulty in breathing, fever, malaise, fast respiratory rate, and RT-PCR positive for COVID-19 virus, when there is swelling around the eye with bulging or prominence of the right eye. The classical condition, the classical description is mucormycosis, and this is a fungal infection caused by mucor, right? So here you can see there is periorbital inflammation. Fine. So this is all mucormycosis. And the moment you find the word COVID-19, any pathology surrounding the eyes or palate or upper cheek and all, straight away jump to mucormycosis. Clear? And the treatment is amphotericin B. So these are some basic facts which one should know. So previously it was a very favorite, but nowadays we don't have questions from COVID-19 as such. Now, multiple perforation of tympanic membrane. The moment you have this word, yes, liposomal amphotericin B, Mohammed Anas, absolutely right. If you see multiple perforations in tympanic membrane, there is only one condition that should come to your mind, and that is tubercular otitis media. Clear? So this is tuberculosis. No, Chaitanya, this is tubercular, right? Multiple perforations. The moment you find this word, multiple perforation, here you can see one perforation, second perforation, third perforation. So 3 perforation. Yes, Mohammed Anas, this is tuberculosis. In cholestoma, just to clear the doubt of Chaitanya. Cholestoma, it is associated with marginal or aticoantral perforation. Clear? So this location is very important, and there is, granulation tissue formation, and this can involve the bone as well. And the discharge is, the ear discharge is very bad odor, although less in quantity. Right? So this is about the ear discharge. So this you much know about cholestoma, which can involve the nearby bones. Now, next question, very good. There is a case of head injury, and then patient developed unilateral conductive hearing loss, and on examination, the tympanic membrane was normal and mobile. What could be the reason for this conductive deafness? Now, if there is head injury presenting with conductive deafness, the very first possibility is there may be perforation of tympanic membrane. Right? So this is one possibility. But it is already mentioned in the question that there is no perforation. So this option is ruled out here. Now the second condition which can be possible here is the disruption of the joints of middle ear ossicles. Clear? Because they are responsible for sound conduction. So if this is not the option here, then second is some dislocation of the joint between the middle ear ossicles. So the answer here is obviously dislocation of the incudostapedial joint. So it means this joint is damaged here, this one, because this is incus and this one is stapes. So this joint is damaged here, and therefore there is no conduction of sound. Now, collection of fluid in the middle ear, this is known as serous otitis media, and this is especially seen if there is blockage of nasopharyngeal opening of eustachian tube, and this is classically seen with either we just discussed about nasopharyngeal carcinoma, the other condition is adenoid hypertrophy. So it has nothing to do with trauma as such. Clear? So this option is ruled out here. Facial nerve palsy cannot result in conductive deafness, we all know that. And acute suppurative otitis media, this is an infective condition. It has nothing to do with trauma. So the answer is disruption of the incudostapedial joint, and therefore there is no conduction of sound. So it's very easy to reach up to the answer. Just injury, think of two possibilities: either there is perforation of the eardrum or there is some dislocation of the middle ear ossicles joints. Now, a child, unilateral, foul-smelling nasal discharge. Whenever you have a child with one-sided, bad smell nasal discharge, think of a neglected foreign body. Clear? So this is a classical case with foul-smelling nasal discharge, foreign body. Very good, Mohammed Anas. And this is neglected. The child has forgotten about that. Now moving forward, a diabetic lady having destruction of the nasal portion of the face, and she just recovered from COVID-19 infection. So I already told you, if there is any of post-COVID-19, especially in a diabetic, any involvement of the face area, straight away the diagnosis have to be mucormycosis, and for mucormycosis you need to give, yes, LAM, yes. So liposomal amphotericin B. Clear? So please mark the keywords: post COVID-19, diabetic, involvement of the face, mucormycosis, straightforward. Now, not a component of Trotter's triad. This we have already discussed in the very first question, very initial question. And here we discussed one thing, that there is temporoparietal neuralgia, conductive deafness, and palatal palsy. So we are left with the answer is straightforward, that is seventh nerve palsy. So seventh nerve palsy is not a case here. So this is temporoparietal neuralgia. You can remember it in a much better way. Now, moving forward, a 5 years child has nasal discharge and nasal obstruction, and there is past history of recurrent infections. On examination, the child was breathing from mouth. He has a high arched palate, most likely diagnosis. Now, if you directly jump onto the image without looking for the MCQ statement, you might think it of as a juvenile nasopharyngeal angiofibroma, but we have to study the questions very well. So there is nasal discharge and therefore there is nasal obstruction, and the patient is having frequent nasal infections, and the patient is breathing from mouth. Now, why the patient is breathing from mouth? Because there is nasal obstruction. So because of nasal obstruction, the patient is forced to breathe from mouth, and just because of this there is high arched palate. Yes, Mohammad Anas, absolutely right. So this is a classical case of adenoid hypertrophy. Clear? So adenoid hypertrophy, and see, actually adenoids are a group of lymphoid tissue which regresses by 11 years. So this condition is always seen before the age of 11 years, number one. So that is 5 years in the question, right? After 11 years, there is nothing like adenoid hypertrophy because the adenoid as such does not exist, it regresses. But what happens, since the adenoid is in the nasopharynx, when it enlarges, it blocks the nasal cavity and therefore there is nasal obstruction. So suppose if this is the nasal cavity, the adenoids are usually here, normal adenoids. So there is all way for the air to pass from nose to go like this. But what happens if the adenoid enlarges? If adenoid becomes hypertrophied like this, obviously they are encroaching upon the nasopharynx and they are blocking the nasal pathway. Therefore the child is forced to breathe from mouth, and if you look at the face, he has got a open mouth. Clear? So this is one thing. So if you write it as one, open mouth. Secondly, what you will see, there is no nasolabial folds. So absent nasolabial folds. These are the skin folds present between the nose and the cheek, nasolabial folds. Third, you will see that there is dental malocclusion, so dental malalignment, especially upper teeth. So dental malocclusion, right? And fourth, there is atrophy of LR nasi muscle. So there is atrophied LR nasi muscle, and this causes pinched nose appearance. Clear? So this is a classical thing. Now one more thing, since the adenoid, when it enlarges, it can block the Eustachian tube. So these children, they might have serous otitis media which presents as conductive hearing loss. Okay, so this is conductive hearing loss. So in school, they will not be performing good, and because of conductive loss, they will not hear what the teacher is saying, and the teacher will feel as if the child is inattentive in the class. Clear? So this is inattentive behavior. So that's very important here. I think everything is okay with the net. Okay, is everything okay? Audio and video is okay? Please drop me a message, and I am extremely sorry for that technical glitch. If everything is okay, just drop me a message and then I'll proceed. Okay, thank you, Anas. Yes, this is a classical frog face. Yes, thank you, Chaitanya. Right? So I think these few features will help you in identifying the case as a case of adenoid hypertrophy. Clear? Yes, it looks like juvenile nasopharyngeal angiofibroma at the very first sight, but I'll request you just look at the keywords and just make sure that you don't mark it wrong, because this is a scoring question and it should not be done wrong at any cost. Clear? Moving forward. Now, some ear procedure was done and the patient started coughing. Now, this is because of irritation of which nerve? Now here, to understand this, we should know the nerve supply of external ear. And if you look clearly, there are few nerves which are on the lateral aspect of external ear. One is the auriculotemporal nerve, right? So the auriculotemporal nerve. Now this one is the auriculotemporal nerve. Now the name is auriculotemporal, so it means temporal part. Auricle means ear, so auriculotemporal nerve. Then another important nerve is, which is in fact the dominant nerve, and this is the great auricular nerve. Great auricular nerve. And then in the middle there are two nerves. One is of course seventh nerve, and third is the auricular branch of vagus nerve. Auricular branch of vagus nerve. Now this auricular branch of vagus nerve is also known as Arnold's nerve. Clear? And this is the nerve, if it is irritated, it will cause coughing reflex. Clear? So the answer is, Anas, you are absolutely right. This is auricular branch of vagus nerve. Auricular branch of vagus nerve, and this is also known as Arnold's nerve. Clear? So Chaitanya, this is not facial nerve. This is auricular branch of vagus nerve, which will cause coughing on any procedure done on external ear. Now, next question is about tuning fork test, and this is about Weber test, and the condition is conductive deafness. Now, what you will find here. Now, before jumping on to the answer, I would like to give you the concept first. Now, what actually we do in Weber test, we tap the tuning fork and we'll place it in the center of the forehead. And we will tell the patient, please tell us if you hear better in one ear or you are hearing equal in both the ears. Now, that term is known as lateralization. Clear? So, normally there should be no lateralization. There should be no lateralization. It means the sound should not be heard better in any ear. It should go equally in both the ears, right? So equally in both the ears, there is no lateralization. Patient will not say I am hearing better in right or left. Now, suppose the patient has come to you with, say, pathology in right ear, just for example, and you are thinking whether it is conductive deafness or not. So what will happen, the moment you will keep the vibrating tuning fork, patient will say here, patient will say that I am hearing sound better in right ear. Clear? So it means in conductive deafness, the patient here is hearing better in the diseased ear. Sorry. So the patient is hearing better in the diseased ear. So this is known as lateralization to the affected side, and this is an indication of conductive deafness in the affected side. Now, suppose if the patient is having, again, right ear pathology, but the patient is saying that I am hearing better in the left side, means in the opposite side. So it means on the right side there is sensorineural deafness. Clear? So, Muhammad Anas, in Weber test, normally no lateralization, clear? No lateralization here, but in conductive hearing loss, lateralization to same side, and in sensorineural hearing loss, there will be lateralization to opposite side. Just remember this much. And same side, opposite side means the side to which the problem is there. So same side, suppose if we are taking right ear, it means it will go to right ear. Opposite side means it will be felt better in left ear. So is that concept clear? This is Weber test, and we ask for lateralization, or like in which ear you are hearing better. If the patient hears better in the diseased ear, it means in the diseased side there is conductive deafness. Is the patient is hearing better in the non-diseased side, it means in the diseased ear there is sensorineural hearing loss. Clear? So this is how we use the Weber test to determine whether there is conductive deafness in the diseased ear or sensorineural deafness in the diseased ear. Then moving forward, 16 years boy presented with epistaxis, and there was a mass protruding from the nose. Most likely diagnosis. I think this is a pretty straightforward question. Pubescent male, right? So pubescent male, recurrent epistaxis, and there is a mass which is very good, very good. So this is a classical description for juvenile nasopharyngeal angiofibroma. Clear? So this is a classical description. Now here, don't mix up with rhinosporidiosis, okay? Because the moment some student, when they find this word red mass from nose, they jump on to rhinosporidiosis. But this is frequent epistaxis, and please do notice the age and the gender as well. So classical description for JNA. Very good, Anash. Very good, Chaitanya. Now, Rinne's test is positive in. Again, this is a tuning fork test. And what actually we are checking here? We are checking air conduction, and we are checking bone conduction. Right? So, AC and BC. Now, what is happening? We will tap the tuning fork, and we will place the tuning fork over the mastoid process. And we will ask the patient, are you hearing any sounds? The moment the patient says that I'm not hearing any sounds, we will remove the tuning fork and we will place it in front of the external auditory canal. If the patient is hearing the sound, it means the air conduction is more than the bony conduction. If we keep it over the mastoid, that we are checking bony conduction. If we are keeping it in the front of the external auditory canal, we are checking air conduction. So if the patient is still hearing, if we keep the tuning fork in front of the external auditory canal, it means AC is more than BC. And the test is said to be positive. Now, in a normal person, this should be the case. In a normal person, air conduction should be more than bony conduction. But in a patient with sensory hearing, neural hearing loss, we will have the same equation. So if a test is positive, AC is more than BC, you can have two possibilities. Either the person is normal or the person is having sensory neural hearing loss. So Chaitanya, Mohammad Anash, you both are right. But now the question is, how we will determine whether the patient is having conductive hearing loss, whether the patient is normal, or whether the patient is having sensory neural hearing loss. So to differentiate these two conditions, we will go for Weber test. So here the Weber test will save us, and if the sound is going in both the ears, it is normal. If the sound is going towards the opposite ear, the case is a sensory neural hearing loss. So the Weber test is valuable, especially if the Rinne test is positive. In negative, we need not go for Weber test, because that is clear that if bone conduction is more than air conduction, it means the test is negative, and this suggests that the person is having conductive hearing loss. So here we need not go further, but especially in a positive test, we have to go for Weber test. Then moving forward, again one more question on Rinne's test. Which statement is not true? And most of the things we have already discussed, and I'm very sure all of you can mark the right answer here. Let me see what's your opinion on this question. So I'm waiting for your answers. Please mark your answer, A, B, C, D, whatever you want to say. Chaitanya, Anash. Yes, come on. It's not that tough question, gentlemen. Just you can see something, you can just learn from this upper question. So if air conduction is more than bony conduction, yes, this is normal. So option A is right. Air conduction is more than bony conduction, it can be normal. Air conduction more than bony conduction, it can be sensory neural hearing loss, that's also right. Then bone conduction more than air conduction, that is negative test, conductive hearing loss. Yes, Bhavesh, you are absolutely right. So top three options are very correct. So the answer is the fourth option, that is air conduction more than bone conduction in dead ear or severe SNHL. Now what is this entity, dead ear or severe SNHL? So dead ear or severe sensory neural hearing loss. Now what happens here? Ideally, yes, Anash, absolutely right. There is no conduction at all. So there is no air conduction and there is no bony conduction. Clear? Because that ear is dead. But what happens when we examine the patient, we find that bone conduction is more than air conduction. So this is what? Bone conduction more than air conduction is what? Negative test. Right? So this is negative Rinne's. But what is happening here, this bone conduction, whatever is occurring, it is occurring because of the other ear, right? Not because of the ear which is under evaluation. So therefore, the other ear is giving us the wrong information, and therefore we use the word false negative Rinne's test, right? So in dead ear or sensory neural hearing loss, which is of severe variety, we will see bone conduction more than air conduction, but that is false, because the bony conduction which is occurring, it is occurring because of the other side. And therefore, when we are evaluating this case, we have to block the opposite ear, right? So we have to block it, and for that we put a box, so there is no bony conduction from other side. Clear? So this is how to avoid this false negative Rinne's test. So this is for dead ear or severe sensory neural hearing loss. Then moving forward, not an attachment of quadrilateral cartilage. I think most of you can understand where this is in nasal septum. Okay, so nasal septum has two parts, bony part and cartilaginous part. Now to answer this, let us take the help of an image that which of the bone is not connecting with the quadrilateral cartilage. So if you see here, this one is the quadrangular cartilage. Okay, so this one here is the quadrangular cartilage, and let us see which bones are connecting to this. On one side, this is perpendicular plate of ethmoid. Okay, so perpendicular plate of ethmoid, this is right. Then on the other side, you can see this is the vomer bone which is connecting. So vomer is also right. Then still lower down, you will see this is the maxilla. So maxilla is also attached. So maxilla is also right. So ethmoid, vomer, maxilla. These are the three bones which are connecting here. But the fourth one, where is the fourth? This is the sphenoid. So sphenoid is the answer here, and you see sphenoid has no connection whatsoever with the quadrangular cartilage. So this is sphenoid sinus here. Okay, so this all is sphenoid sinus. Clear? Then this is sella turcica, which lodges the pituitary gland. Okay, so this is sphenoid bone. Okay, so quadrangular cartilage does not have any connection with the sphenoid bone in relation to this question. Then moving forward, a child presented with ear pain and there is markedly congested tympanic membrane. Now when we say congested means rich in blood supply. Right? So if you look at the tympanic membrane, you will see that it is so much red, so red all around. Clear? So it means there is some inflammatory pathology. So this congestion indicates there is some inflammatory pathology. Then only there will be too much of blood supply, and that will cause congestion. Now at the same time, what you can see, there is purulent material also. So this yellow is all pus. Clear? So this yellow is all pus. So you can see the purulent material also. So this is all pus. Clear? So this yellow is all pus. So you can see the congestion and you can see the purulent material. So I think most of you can answer this condition very well. This is acute suppurative otitis media. Acute means presenting within very short span of time. Suppurative means pus forming. Otitis media. Media means middle. Auto is ear. Itis is inflammation. So suppurative inflammation of the middle ear. Very good, Mohammad Hanas. This is ASOM. Clear? And this is also seen in children. So this is a classical case of ASOM. Now see, there is already pus formed. So if you don't do anything, it will cause perforation of the tympanic membrane. And then it will come out. So as a doctor, what's our duty? Before there is perforation, we should do myringiotomy. So let us make an opening in the tympanic membrane and let the pus come out. Otherwise, this is the natural course. So this is the treatment by a doctor. Okay, so give an incision, let the pus come out. Of course, we need to give IV antibiotics as well. So this is a classical ASOM. Then moving forward, Which is the most common cause of stridor in neonate? Now this is one very favorite question as and has been repeated over the years almost in every exam. So this is specifically inspiratory stridor. Now what is this condition in a newborn? Inspiratory stridor. What will be your answer? There should be no need to jump onto the options. Straight away the answer should click in your mind, and this is Laryngomalacia. Clear? This is Laryngomalacia. Very good, Mohammed Anas. Now, what does this word Malaysia means? Now, this is not the country Malaysia. Malaysia here means weakness. So, what happens because of this weakness when yes, very good. When the child when the child inhales, there is inward sucking of the supraglottic part, right? So the supraglottic part move inwards. Clear? This is all supraglottic part which moves inwards, and therefore the shape of epiglottis becomes omega shaped. So this is the symbol omega, something like this. Clear? So this is known as omega shaped epiglottis, a classical finding of Laryngomalacia. Right? So this is just because the supraglottic part, this is the supraglottic portion, okay? This is the supraglottic portion. It is sucked in, and therefore it creates a omega shaped epiglottis. Very good, Mohammed Anash. And I think most of you must be knowing treatment is nothing. Just wait and watch and assure the patient, the parents, because this condition will resolve by the age of 2 years. Very good. So resolve by 2 years. So need not do anything. It will resolve. Now, which nerve supplies above the level of vocal cords? Now here, if suppose this is the vocal cord, different nerve provides sensory innervation above and different nerve provides sensory innervation below. So above is internal laryngeal nerve and below is recurrent laryngeal nerve. Clear? So for above, the answer has to be internal laryngeal nerve. Yes, it is a branch of superior laryngeal nerve, and below is recurrent laryngeal nerve. This is a branch of recurrent superior laryngeal nerve. No problem. Okay. So this is coming from superior laryngeal nerve. So the answer is internal laryngeal nerve, right? So this is internal laryngeal nerve. Clear? Then moving forward, a child with otitis media not responding to ampicillin, okay, and is having bulging membrane with a dull look. Now what you need to do? Firstly, of course, you need to make the clinical diagnosis. Now here, there is otitis media, of course, but it is not responding to antibiotics. It means it is not inflammatory. So this particular clues tell you that it is not infective or inflammatory. So it is not infective here. Now, which type of, and therefore, what we see, the tympanic membrane is dull looking, because we just discussed like how the tympanic membrane looks in a case of infective condition. So it means this is not an infective condition because it is not responding to antibiotic and it is having a dull look. So it is not infective. Now what is that condition which is affecting a child and resulting in otitis media? The answer is serous otitis media. Okay, so in a child only there are two conditions in terms of otitis media which you need to remember. One is ASOM and the second one is serous otitis media, which is also known as glue ear or also known as otitis media with effusion. Clear? So there is a same condition, three terms. The condition is same. Now what we need to do? we need to do, very good, we need to do myringotomy first, but it should be supplemented by a grommet insertion, right, or what you call a ventilation tube. And if there is adenoid hypertrophy, at the same time adenoidectomy, because I told you that the enlarged adenoids, they might block the nasopharyngeal opening of eustachian tube. So unless and until you remove the adenoids, that blockage will not go away and the fluid will not resolve. So you have to collectively treat the patient. So think of serous otitis media, okay, it's okay, you are doing this for that, but at that same time also think of the pathology which is behind this, but all presentation. So that is usually adenoid hypertrophy. So for that we need to remove the adenoids as well. Clear? Now a patient is having scanty, foul smelling discharge from the ear. It means there is some ear pathology. Then there is hearing loss. Now what is that condition which can cause hearing loss and which can cause ear discharge? And this is foul smelling, scanty. I already told you before while we were discussing cholesteatoma. So this is cholesteatoma, right? And this is again a bony involving entity, and therefore the discharge is very bad smell. So cholesteatoma, and this is seen with unsafe COSOM, in which the perforation is aticoentral or marginal. And for this condition, what we need to do? Modified radical mastoidectomy. Clear? So we need to do this MRM, modified radical mastoidectomy. Clear? Because this is a case of cholesteatoma. So hearing loss, this is what type of hearing loss? This is conductive, because there is perforation, right? Because there is suppurative otitis media, and there is which type of perforation? Aticoentral perforation. Clear? So this is conductive hearing loss. So this is how the facts can be, joined together to be more confident about our answer. Then moving forward, a child is having recurrent episodes of otitis media. Now child, recurrent episodes, otitis media. Now in one of the questions I told you that there is a child who is having recurrent infections. So it means there is recurrent infections in the form of adenoid involvement. And when there is adenoid involvement, that is adenoid hypertrophy, which type of otitis media will come? Which type of otitis media will come? Whether it will be acute suppurative or serous. I think the answer is pretty clear. This is serous otitis media in adenoid involvement or adenoid hypertrophy. And for serous otitis media, we already discussed, of course, there is adenoid involvement, so remove adenoid. Clear? So remove adenoid, adenoidectomy. And there is serous otitis media. For serous otitis media, we already discussed what we need to do. We need to give an incision in the tympanic membrane, and we need to put a ventilation tube. So we need to do myringotomy plus grommet insertion. Clear? So this is a typical case of serous otitis media. So anytime if you find anything related to adenoid, always go for serous otitis media, because a child with acute suppurative otitis media will be very, you can say, toxic and very high fever, severe pain in the ear. Here there is no pain in the ear because this condition is not infective or inflammatory. So serous otitis media, and this is how we can see this is fluid level. Clear? So here you can see a classical fluid level. So this is otitis media with effusion, or what you say, serous otitis media. Clear? Sometimes we see multiple air bubbles. So that is all serous otitis media. Now, a patient with Bell's palsy comes to you with deformity of face. Now, what type of paralysis is this? Now, Bell's palsy is what? Upper motor or lower motor? Of course, this is cranial nerve 7th affection, and this is lower motor neuron palsy. Clear? So, very good, Mohammed Anas. This is lower motor neuron 7th nerve palsy. Now, what happens in lower motor? It will affect which side? Same side or opposite side? It will affect same side, right? So if I say, if there is a right side facial nerve palsy, there will be right side complete paralysis of face, right? So this is right side. So this is in case of Bell's palsy, or you can say lower motor neuron palsy of facial nerve. So in lower motor neuron palsy of cranial nerve 7th, that is Bell's palsy, same side complete half will be paralyzed, and there is a very classic appearance. The moment you look at the patient, you can say this is a case of right-sided lower motor neuron facial palsy. Look at the angle of mouth. On the normal side, it will go up, and on the affected side, it has drooped down. So, the angle of the mouth will be on the lower side, on the affected side, and the normal muscles of the other side, they will pull it up. So, this is on the upper side because the normal muscles are pulling it up. So, you will always see a oblique mouth. And yes, there is involvement of forehead as well. So there will be loss of forehead markings. Patient will not be able to close the palpebral aperture. Okay, so this is classical lower motor neuron palsy. Now what happens in upper motor neuron palsy, which can be seen in stroke? This is known as supranuclear. So this is upper motor neuron. Now in upper motor neuron, what happens? There is opposite side lower half. So here this is the lesion is on the left side. Okay, so the lesion is on the left side in the brain, and the manifestation is on the right side involving the lower half, right? So this is right but lower half, and here we saw complete half. So two important points which you should take from here: complete half, same side, upper motor neuron; lower half, opposite side, upper motor neuron. Clear? So, and why the forehead escapes here? Because the forehead has bilateral innervation. So forehead has bilateral innervation, and therefore it escapes injury in upper motor neuron lesion, that is supranuclear. So for the time being, just remember one thing: lower motor, same side, complete half, right? So just two keywords: same side, complete half. And in upper motor neuron, if you can remember, opposite side, lower half. Okay, so this is opposite. If the lesion is on the left side, there will be paralysis of the right side facial nerve. Clear? So this is how you can remember the basic difference. Again, the angle of mouth, you can see it is tilted, but forehead is spared here. So forehead spared, and here forehead involved. Clear? So this is difference between upper motor neuron and lower motor neuron palsy of facial nerve. Clear? So I think this much is enough for this session. I'll come with other subjects as well. So see you soon. Till then, study well. God bless. Bye bye.